Hello, good afternoon, good evening, and good morning to everyone joining to this week's Ask WHO session about COVID-19. I'm joined by Dr. Mike Ryan and Dr. Maria van Kekrhove. So if you have any questions about the current COVID situation, sub-variants that we are reading a lot about in the news nowadays, please send us your questions if you're watching us on Twitter using the hashtag AskWHO, or if you're watching us on other platforms using the comment section. Mike, Maria, good afternoon. Thank you for your time today. Earlier this week, we had a press conference that has had a lot of coverage in the news, especially when the Director General said that COVID pandemic is not near over. So maybe you can share the current epidemiological situation and updates with our viewers before we start taking the questions.
So hi Alex, it's good to be back. Yeah, unfortunately, of course, the Director General is correct. The pandemic is not over, and we're still dealing with this virus, which is highly active around the world. So we're still continuing to track the circulation of the virus, how the virus changes, and the impact of the virus. What is it doing in people? How many people are requiring hospitalization, need for advanced care within hospital, and how many people are dying? So it's really important that those activities to track it remain. So globally, we've had, in the last 7 days, we've issued our 100th weekly epidemic report of COVID-19 this week. And in this 100th edition of this weekly report, which at one point we were doing daily, so a massive thanks to our teams in-house and around the world who contribute to that. In the last 7 days, more than 5.7 million cases were reported to WHO, and that's an increase, and we are seeing an increasing trend in case reports. But we do know that this is in the backdrop of reduced surveillance activities, reduced testing. So this is an underestimate of the number of cases that are out there right now. And we are seeing increases in reports of cases in 4 of our WHO regions. In the European region, which had more than 2.8 million cases reported last week alone, which is about 50% of the cases reported in the last 7 days. We have an increase in cases reported in the Western Pacific region, in our Southeast Asia region, and in our Eastern Mediterranean region. And we saw a reduction in cases being reported from the Americas and across Africa. And so seeing an increase in cases at this point in time is concerning, again, given that we know that that's an underestimate because surveillance activities have changed. While self-testing has increased, it's not captured in our reporting systems. With regards to deaths, 9,872 people were reported to have died in the last 7 days alone. Almost 10,000 people dying. That's far too high given that we have measures in place that can prevent them. That's a slight decline than we had in the week previous to this, but it's still far too high. We saw an increase in deaths in the Southeast Asian region and in the Eastern Mediterranean region, with reductions around the world, the rest of the world, and a stabilization across Europe. So this is not the position we want to be in. These levels of death are similar to what we saw in March 2020, but in March 2020, we did not have therapeutics. We did not have vaccines. And so to see this level of death, even though it's a reduction, because we are seeing increasing population level immunity, and that's a very good thing, it still shouldn't be this high because we have the tools that can prevent them. So we are quite concerned at this level that we are at within the pandemic. While being positive, we do see the decoupling of cases and deaths with the use of public health tools, with the use of medical interventions like vaccines, therapeutics, and getting people into clinical care early. So it's a mixed picture, as it has been throughout this pandemic, but we are quite concerned at seeing this level of death as well as this level of circulation at this point in the pandemic.
Thank you so much, Maria. And Mike, given this current situation that is a bit worrisome, what is that worries you the most as we are in third year of the pandemic and we are seeing waves coming back again, and that people in many places are behaving like pandemic is over, but what we are seeing from the virus behavior and epidemiological situation is quite the opposite.
Yeah, well, I think the worrying thing, certainly in looking at the data in Europe over the last number of weeks, to see that rate of hospitalizations tick up, and in some countries, like my own, seeing the rate of ICU occupancy go up. and then seeing death rates increase in some places. So I think what we've seen overall, the good news, I suppose, overall, is where we see very high levels of vaccination, especially booster doses being used in vulnerable people, we see very much a flatlining. In other words, an increase in incidence doesn't lead to a consequent increase in deaths. The system works and the hospital system doesn't come under pressure. You may see a small rise in hospitalizations, but seeing that quite sharp rise in hospitalizations in some European countries, really indicates that there are still gaps in immunity. There are still people who have not had a full course of vaccine, or that we're seeing waning immunity, particularly in some vulnerable groups that may require further boosting. But what we're seeing is a gap in our, as Abdi calls it, our wall of immunity. And in that sense, our defences, and it's like anything, you can imagine that if you build a wall to defend your castle and you don't tend the wall and you leave it there for years, well, eventually, it gets weak, it gets cracks, there are holes in the wall. It's just time. Over time, our immune system may wane in its capacity to respond. The vaccine gives you an immunologic memory, but that fades over time. And that's where I think we need to be careful. Those people who remain unvaccinated or maybe highly vulnerable or older persons who've only had 2 doses and haven't had a booster, that creates another potential gap in immunity. And also the fact that the current subvariants are quite antigenically distant, and I mean by that they're a bit further away from the ancestral strain in terms of the immunity that they will elicit. So therefore, the vaccines aren't quite as good at protecting you against that particular strain. The ancestral strains vaccines, the ones that all the vaccines contain the sequences of that ancestral strain. They're excellent. They're absolutely superb. But they're not quite as effective in preventing infection with these more recent strains. But they are very good still at preventing hospitalization and death. So what I suppose, we want people to be out there. We want people to have their summer. We want people to have fun. But what we want governments to be doing is looking at national plans and saying, okay, have we got everyone vaccinated that we need to have vaccinated? Have we boosted everyone that needs to be boosted? Have we found those people we haven't found? Have we got antivirals in place? Have we integrated antivirals into primary health care? In other words, do the general practitioners, the family doctors know about the antivirals? Do they know how to prescribe them? Do the pharmacies have them? Do we know the right people to put on those antivirals? Because that's our second line of defense now. And thirdly, governments need to be thinking about keeping up testing, keeping up sequencing, so we can keep an eye on where this virus is. And I think a lot of governments are doing that, but I think some governments have kind of decided, well, just like people on the street, it's all over. And I think there's a difference here. I genuinely want ordinary people to go and enjoy the freedom of being able to mix again, being able to see family and friends, to be able to go on holidays, and because we've all been through a tremendous trauma of lockdowns and restrictions. But that doesn't mean that governments can step back. Governments need to continue now to look at that wall of immunity, to look at our clinical capacities, to look at surveillance. Now is the investment we make. Because to be quite frank, if we don't fill those gaps now, if we don't strengthen our clinical systems now, if we don't get the antivirals into the system now, what might be a small problem now could become a much larger problem as time goes by, as we head towards the winter, as we head towards more mixing inside. So I think prudent governments are now really looking at their plans, really looking at the strategic response plans and seeing, do we have everything in place? Are we looking for every gain we can make against this virus? Having said that, individuals do bear responsibility, and particularly people who are themselves vulnerable still need to be taking precautions. And there is no need to get repeated infections. A colleague of mine said the other day that many people now are boasting about the fact, I've had this 4 times. I wouldn't like to have COVID 4 times, and I do think there's some evidence to suggest that sequential COVID infections do result in higher risk of long-term, long COVID or cardiovascular and neurologic complications. You don't want to get this disease once if you can avoid it, and you don't want to get it 4 times for sure. So I do think there's a need for us all to have that risk management where we can try to prevent ourselves getting the disease unnecessarily. I think there's a particular group we need to support, and I've seen this, witnessed this myself in the last week, being on the number 8 bus, being the only person on the bus wearing a mask, and another person was wearing a mask, and they were questioned by somebody else as to why they were wearing a mask. And I think it's an awful position to put somebody in, because that person was taking care of someone at home that they didn't want to bring the disease to. So I think that we need to be really careful that you make decisions for yourself, and yes, within the rules, you go on and do your thing, and if you're not required to wear a mask, fine. But if somebody beside you on a bus, if somebody sitting you in a waiting line, if someone sitting beside you on the plane is wearing a mask, they probably have a very good reason for that, for their own health or for the health of someone they love. So we should support and encourage people to be able to take precautions. And I must say I've noticed a kind of a backlash, what are you worried about, it's all over attitude, and I think that's unacceptable, quite frankly. We should all be in a position where we can take the necessary measures to protect our own health or the health of the people we love, and we should not be criticised for taking those precautions, at the very least. And people shouldn't feel embarrassed or shouldn't feel stigmatised because they're taking those precautions. So that's a very important message that we try to get out there to everybody. So in a sense, we want people to have fun. Be careful in doing that. Be smart. Watch your distance. Remember where you are, who you're with, and try to ensure that you don't get into a situation where you end up with lots and lots and lots of transmission. But it's very hard to give that advice to people. When the rules say you don't have to do it, when the government is saying you don't have to keep distance, when there are no restrictions on the number of people going into nightclubs or going into, it's very hard to turn around and say, well, you need to take the precautions. So at the very minimum, I will be saying to people who have any concerns about their underlying health, if you are not vaccinated or you have an underlying condition or you are vulnerable to severe disease, you should still be extremely careful about how you mix with others, especially now that we have increasing transmission. At the very minimum, we should be encouraging people with those situations to take precautions, and we should be asking everybody else to support them in taking those precautions.
Alex, I just come back from a couple weeks of being away, and I had a lot of people ask me, like, aren't you tired of saying the same things over and over again? And the fact is, I mean, we would love to not have to say the same things, but it's important that we do, because the risk is still there. I mean, the perception may be that the pandemic is over, but unfortunately it's not. And it is our responsibility to ensure that we work with governments to make sure that they have the right systems in place, as Mike has described, and use the time now for preparing. Pandemic preparedness for the next one doesn't start when this one is over. Pandemic preparedness is now. But it's about you and keeping yourself safe. We have this new campaign that's out, talking about your life, and your life is precious. But we've had previous campaigns around of just knowing your risk, lowering your risk, and being kind to others and supporting others in the actions that they take is part of that. I have also noticed this backlash of saying, well, why are you wearing that mask? Why are you doing this? And it really is important because the virus is circulating and there are vulnerable people that remain out there. So you think about yourself, living your life. Live your life responsibly. Live your life carefully and as careful as you can. Don't stop doing things, but do them a little bit more carefully. And many people around the world, not everyone, has access to these tools. We have self-testing. So you can self-test if you're going to a gathering. Wearing that mask remains critically important when you're in enclosed spaces, when you're on public transportation, when you're in enclosed rooms. Spending more time outdoors continues to be important. This virus is incredibly transmissible. And while the vaccines work very effectively at preventing severe disease, they're not as effective as preventing infections. So the virus will circulate. And that puts the virus under pressure to change. And that puts the virus under pressure to continue. That's its job. It's not alive, but that's its job, is to continue to replicate. And it is taking advantage. So we're in the northern hemisphere where we're filming this, and we're in our summer months, but the southern hemisphere is in their winter months, and they have a colder type situation. People are spending more time indoors. We're seeing a rebound of influenza and other pathogens that are circulating. So these measures have an impact not only for COVID, but for other diseases as well. Summer in the Northern Hemisphere is not a time to stop being vigilant. It's not a time for a free-for-all and say, oh, we'll just deal with it in a couple of months. Be careful. And as an individual within your families, and make sure who you come in contact with, you take them into consideration, because many people have underlying conditions. And governments, I agree with Mike wholeheartedly, Governments need to use this time to make sure that they have right-sized the situation, the response that they have. Surveillance, testing, sequencing, clinical care, personal protective equipment, looking at the support for people to work from home or to stay at home, investing in ventilation. It's not just about individuals opening windows, but it's about investing in ventilation in the buildings where we live, we work, we play, we sleep, we go to school, and doing that in the right, responsible way. So there's a lot that needs to be done, and that's our job, to keep being a broken record about this. But we think that there's value in doing so because 10,000 people are dying every week from a disease where we have tools that can prevent that from happening. Maybe not all of them, but certainly a large proportion of them. And that's what our job is to make the world safe, or make the world safer, and to keep people alive. So we will keep being that broken record. So no, we're not tired of saying this over and over again. We want the pandemic to be over, and we hope you don't have to see our faces in doing this, for the long term. But we feel a responsibility to just have this dialogue.
And the message to governments might be in what the chaos everybody is seeing in airports right now.
Right.
People in airports work very hard, and they have a very responsible job, moving millions of people around, and they do it very efficiently. But during the pandemic, because of the shutdowns, a lot of staff were let go. Most of those airports are back up to 90%, 95% workforce, and yet there's chaos. It's amazing how small a percentage of available workforce or available infrastructure will put you in a very difficult situation. Because when a system fails, it tends to fail when a complex system fails, it fails in a very complex way. And we've seen that. And all of you out there have probably been in a queue, in a line, in the last 8 or 10 weeks going, oh my God, how many hours does it take to get through here? And you can see all the staff, and it's the same technology, and there aren't any more flights, and you're wondering, why? Because systems don't just take off again. Systems, if you take the resources out of a system, and then you expect the system to work when you press the button, it doesn't happen. And my fear in this with testing, my fear in this with hospitals, with PPE, with vaccination and other things, is that as we de-invest in this, and it's impossible in some countries to even get a test. Testing centres have closed down. That's fine. But are we ready to open them up again if needed? And look what happened in the thing. When we press that button, can we bring back these services? Will PPE get distributed quickly to hospitals if we get an increase in ICU rates? Will there be enough ICU beds? Will we have enough ICU nurses? If you asked the question 6 months ago or a year ago, will we have enough people working on the security lines in the airports? Will we have enough people doing checking? You'd have said, of course we will. Well, we didn't. We fell short by a few percent, and look at the chaos. It almost reflects the chaos we had in our hospitals at the beginning of the pandemic, because the system isn't ready to cope with that surge. We had a surge of people wanting to travel, and we were just not quite there with bringing staff back online in the airport infrastructure, and the result is chaos. I would hate to see that same chaos ensue because we let down our guard in preparation for our surge or an increase in cases. And it's amazing how a relatively small increase in cases or hospitalizations, if your system isn't ready, the assumption that, it's okay because, we had 1,000 admissions a day only a year ago, so we can go to 1,000 admissions a day again. No, you can't. It took you 6 months to get to that ability, right? It took you a huge effort, huge sacrifice to get to that performance. You've let that go. You're not going back to that capacity anytime soon. And you don't even know what that capacity is. And I'm a bit afraid that people are governments are kind of sleepwalking their way a little, making assumptions about how the system will react if there's a surge. And those governments who are looking at that and not taking action, I point you to the situation in the airports. It doesn't take much for a complex system to fail.
Thank you both. We are receiving quite a lot of questions already. So, Maria, maybe you can take this one from Shahid Khan. How dangerous are current variants BA.4 and BA.5?
Well, it's a very acute question, and it's a very good one because I hear a lot about this. So, we're tracking Omicron. Omicron is a variant of concern, and there are many sublineages of Omicron. The latest ones we are tracking are BA.4, BA.5, BA.2.75, and others. All of these variants, these sublineages of Omicron, are variants of concern. I just want to take a moment to clarify a narrative that's out there that WHO needs to give a new Greek letter to each of these sublineages to take this seriously. That is a false narrative, and that's a really dangerous narrative because all of these sublineages of Omicron are Omicron, and they are variants of concern. Having said that, what we're tracking for each of the sublineages is transmission, looking at intrinsic transmissibility. Is the virus itself more able to infect others? But we're also looking at immune escape, which means the body's previous reaction to either a vaccination or a past infection. Does that protect you against infection or reinfection from these variants that are sublineages that are circulating? We look at severity, and we look at the impact of our interventions. Do the diagnostics work? Do the therapeutics work? Do our vaccines work against infection as well as against preventing severe disease? So for BA4.5, these two sublineages are increasing in detection around the world, particularly BA.5. Most of the sequences that are submitted, that have been submitted in the last 4 weeks to platforms like GISAID, have been BA.5. But the number of sequences that have been shared has dropped precipitously and not proportional to the number of cases that are out there. So we're lacking in our ability to really track this. So we do see BA.5 have a growth advantage, which has to do with transmissibility, but also immune escape. So it's transmitting more efficiently. It's the most transmissible variant we have seen of SARS-CoV-2. But I do want to warn people out there, the next variant I talk about will be more transmissible than the last because it has to outcompete whatever is circulating. So that is a factor that we are going to have to deal with. But it is quite inefficiently transmitted virus even from the beginning. Well, one of the things we want to look at is severity. So we have not seen an increased severity signal of BA.5 compared to other sublineages of Omicron. But we have some early days. It's still quite early days, even though some countries have gone through a peak of BA.5. But in terms of your worry out there, I think what we want people to be concerned about or take careful consideration about is any lineage, any sublineage, any virus variant of concern, any variant that is circulating. SARS-CoV-2, in whatever form it is a dangerous virus. But the positive is that we have tools that can prevent infection, and we can have tools that can prevent severe disease. So BA.4, BA.5 are on our radar right now in terms of, and we're discussing this with our TAGV, our Technical Advisory Group on Virus Evolution. The other variant sublineage that we are tracking is this BA2.75. We only have a few hundred sequences of this variant that is available for analysis, and so we have very limited information about BA2.75. Again, a sublineage of Omicron, so this is classified as a variant of concern already. This virus seems to have a growth advantage even over BA.5, but it's very early days in terms of our understanding of this, so we're watching this very closely. What this tells us as an organization is that we will continue to see repeated waves of infection. That doesn't necessarily mean it will translate into more severe disease. So that is why we have to get vaccination up. Early diagnosis and clinical care, very strong, because this is preventing severe disease. The COVID-19 vaccines that are in use right now, which are based on the ancestral strain, are very effective at preventing severe disease and death, including against BA.4 and BA.5 and other sublineages of Omicron. This is what I want the public to hear. So getting vaccinated is really important. So we expect as an organization with our partners that we will see peaks and troughs of infection. Hopefully those peaks will be lower than previous peaks before, but that doesn't mean it needs to translate into more severe disease or increased risk of hospitalization, increased rates of hospitalization and death. So we have to work hard. The bottom line is that all of us have to continue to work hard against whatever virus is circulating. But out there, just know that there are things that you could do to keep yourself and your loved ones safe.
Thank you so much, Maria. And there are also questions from some people why these highly infectious subvariants aren't classified as new variants of concern.
Well, they're all variants of concern right now because they are all sublineages of Omicron. And so the way that we characterize and we assign, the Greek letter, assigning a Greek letter was really about our public communication because the numbers just got so confusing. And quite frankly, this was something that I had asked for because it was very difficult for me and for others here at WHO to describe these. But you don't need a new Greek letter to explain the risk. The way that we assign a Greek letter is if there is sufficient changes in the genotype and also the phenotype, the way that the virus behaves in terms of its circulation, its severity, its impact on interventions. If any of these sublineages behave differently, if we see an increase in severity, if we see huge amounts of immune escape, if we see an impact on our diagnostics or our vaccines, we will give it another Greek name. But right now, all of these sublineages are variants of concern. All of these sublineages are Omicron. So I want the public to be rest assured that we're on this and that we're looking at this constantly. And for us not giving a new Greek letter doesn't signify that we're not concerned. So all of these are Omicron and all of these are variants of concern.
And every variant so far and every sublineage, the one thing that's been constant is each and every one has had a growth advantage over the previous one. So these viruses have just got more and more and more efficient at transmission. And that's perfectly understandable. They're in their own arms race with each other. The battle for survival of the fittest, we've known that for a very long time. So the virus that survives is the virus that infects as many people as it can, or it's more efficient at infecting other people. So that is purely an evolutionary concept, and therefore that pressure is a non-random pressure. That's a very direct pressure on the virus. So we expect any new variant or sublineage that actually survives will be, by definition, more transmissible. It will also, and this is the thing that Maria raises, the real concern for us, that doesn't concern us as much because we have that background of vaccination, we have that background of protection, that wall of immunity. What concerns us is monitoring any immune escape. If that virus were to move significantly away from the other viruses in terms of its immunology, then we could find that previous infection with the virus or vaccination might not offer protection. What we do know is that having a vaccination, a course of vaccination, or having previous natural exposure to the virus, having an infection, does give you a great deal of protection, not against being reinfected per se, but against being hospitalized or dying. That is the key, and that's why, as Maria said quite correctly, we are likely to see repeated waves of this SARS-CoV-2, repeated waves of the same. It could be repeated waves of the same sublineage if it's far enough apart in time, or it could be new lineages coming in. The reason we're having such frequent waves, in effect, is that new sublineages are coming in with the growth advantage. So they're actually accelerating the way, the speed, the frequency of these waves has been driven by the emergence of these sublineages. But it's as those waves occur, what we want to see is a flat line in hospitalization and death. So that what happens is that, and we've spoken about this before, that we disconnect or decouple the epidemiology of viral infection from the impact of the viral infection on the human population. The best way to decouple those two impacts is to vaccinate. Mm-hmm. It's the surest way we have to make sure that the variation in the intensity of transmission of the virus doesn't result in a massive rate of hospitalizations, health system under pressure, and deaths, is to ensure that each and every individual who's eligible is vaccinated, properly vaccinated and primed with vaccination, boosted if that's advised, and that's where we're going to really, and then for those individuals who are vaccinated, who we may have a breakthrough infection with, and that can happen, and it sometimes can be severe, that we're ready and waiting with those antivirals to be able to pick up those at-risk people who do develop are at risk of a very severe infection, and give them the double protection of having the vaccine up front and then being able to add an antiviral to that in cases where we have people with high vulnerability. If you put those two things together, you have a very, very strong chance of really taking hospitalization and death out of the equation. The problem is, as we distributed vaccines in an inequitable fashion, we seem to be well on the road to having the same inequity with antivirals, which is, to me, almost a greater disappointment, because I thought we maybe had learned the lessons in vaccine inequity, but we seem to be repeating the same mistakes with antivirals as we speak.
Thank you so much, Mike and Maria. There are a few questions in terms of whether the tests that we still use are able to detect those new sublineages, as some viewers are commenting that there is a lack of trust in the current tests due to experience of false negative antigen, but even sometimes PCR tests results.
So Yeah, that it's a good question, because one of the things we look at with each of these variants, each of these sublineages, is do our diagnostics continue to work? And there's several different types of diagnostics that we look at. We have the PCR-based systems that are looking at the parts of the virus, the RNA, in people, in the respiratory samples and the samples that are collected. Sometimes they come from the throat, sometimes they come from your upper nose. I'm sure many of you have had many tests over the last couple of years. But we also have these antigen-based tests, which are the self-tests that people do and provide a very quick answer and really mostly capture when people are infectious. And it's been an incredible additional tool that we have added over the course of the last couple of years. We assess them, in terms of their ability to detect in false positives and false negatives, and they're holding up really well. The thing that and it depends on when you take your test compared to when you were exposed and when you are starting to see the virus replicate in either your upper airway, your lower airway. That's also something that we are assessing with each of these variants. As you know, with Omicron, maybe you remember with Delta, we saw quite some replication of the virus in the lower respiratory tract in your lungs. But with Omicron, we were starting to see that in the upper airways, and people were experiencing some upper respiratory disease. But we actually see it in both, in the upper airways and the lower airways. And that has an implication on where the tests are done and how the tests are done. But to the viewer out there, the tests are working really well. The recommendation, would be is look at when that test was provided to you in terms of the course of your exposure, if you know when that exposure was, and really in terms of when you had your symptom onset. And in many times, with many patients, sometimes repeat testing is necessary. I myself have had to do repeat testing, and I know many of you out there have done that as well. Self-testing, if you have access to those, are a very helpful tool as well. And we know that many people are doing self-tests before they do events, if they're going to a gathering, for example, and making sure that, and especially if they're going to be in contact with someone who's vulnerable and they've been vaccinated, I'm going to do a self-test just to see, at the time I take the test, am I infected or not, am I infectious or not, and then take appropriate measures to go for it. But the tests are holding up really incredibly well. But it is something that we are looking at, and it requires a constant assessment and reassessment each time there's a new variant that comes out. So it's quite a lot of work, you can imagine, to have those studies done, to have the feedback come to us to make sure that what's out there is good. There's also some pretty crappy tests that are out there as well. So we would advise going, to the testing centers that exist, to making sure that if you are purchasing tests, to make sure that those are quality assured, and you can see that on the box that's there. We have a list of tests that are up, that are under evaluation from us, and there are many incredible national and sub-national public health systems at point of care testing within your primary care. There are some very reliable sources of where you can get those. But again, those need to be maintained.
And a lot of these antigen tests are available through pharmacies or through reputable supermarkets and others, and they are quality assured. And there's always a chance of a false negative test on an antigen test. They're actually quite good. I mean, in that regard, you can do a second test. You can go if you're really concerned. And I know I've seen friends of mine who've called me up and said, I'm so sick and I've done 2 antigen tests and I'm negative. And I said, fine, if you're concerned, you don't want to go see your mum, go get a PCR. All of those individuals have turned out to be PCR negative. They just had a head cold with something else, and so it's not like other things have disappeared. But I think it's prudent if you've done the test and it's negative, but you were exposed a few days ago to a COVID positive person, then get the test done again. And maybe it's not the night to go out to dinner with your friends until you're sure you're negative. That's the real caring part of this. And again, using antigen tests, and again, this is a very much an issue. I mean, it's not everyone can afford this, but in many countries, antigen tests are freely available and available at a low price. If you're going to visit a highly vulnerable relative or going to visit someone with severe immunosuppression, a $1 antigen test might avoid a major problem of you potentially exposing someone to the virus. So essentially, we working silently to protect those amongst us who are vulnerable, use testing to help you do that, is a very good thing. But it's very hard to get a PCR test in some countries right now, and some of the criteria, it's not easy. And again, that's back to governments. Well, why make getting a PCR test so hard now? Is there a reason for that? And I find that quite strange, that it's become almost really quite difficult. In some countries, if you've got 3 doses of vaccine, they actually say, no, you don't, even if you're sick, you don't need a PCR test. Well, I might want that PCR test because I might be going to see a sick relative and I might be bringing the virus in my nose. So even though I am asymptomatic and I'm very well, I might want to know my status because I may be infectious to someone else. So, and the problem is that the state-based PCR testing has been shut down. Very often those systems were doing the tests as well for people who were just worried, and because of that the market also for private PCR tests has disappeared. So it's even hard to get a privately paid PCR test, and the cost of those tests has consequently gone way up. So people are back to paying $200 for a PCR test. And who's got $200 for a PCR test? It's pure gouging. I mean, it does not cost that much money for a company to run a PCR test. And if someone is charging you $200 for a PCR test, then they're having a laugh. So, you know, that whole process, making it difficult for people to do the right thing again, is just not helpful. And it's not helping them manage their risk. It's not helping us with surveillance. It's not helping anything. And it makes me concerned at times that that's the way things are going, you know.
We have a question as well about how long are people infectious with those new sublineages? Is there any difference to what we previously knew about this virus?
Fantastic question, and I don't have the full data on that. So we are doing reviews of each of these sublineages in terms of, are there any changes in the infectious period when people can pass the virus to others? Our current understanding still remains that people are infectious prior to the development of symptoms, up to 2 days or so before. People tend to be most infectious right around the time they develop symptoms and for those first few days, but they can be infectious depending on what type of disease you have for 8 or 9 days, maybe up to 10 days if you have a mild disease, which is still pretty rough for many people. But if you have more severe disease, you can be infectious for weeks. If you are immunocompromised, some individuals we've seen are infectious for many, many months. It depends. But most people tend to be most infectious around that first 5, 6, 7 days, but it varies. So what we are asking people to do is utilize these self-tests to help you do that. The antigen-based tests work best when there's more virus, when people are most infectious, and which is to an advantage, because if you have access to these tests, you can test yourself. And if you are antigen positive, you should limit your interactions with others. You are definitely infectious, and you can pass the virus to others. Our recommendations still remain to isolate when you are infectious. So we have our recommendations out there. There are some recommendations that say at day 5 you are no longer infectious. That's not true. There are some policies that are in place that say there's a reduced risk of you transmitting the virus after 5 days, but you could still be infectious. So this is really important. But we are looking at this. We also know that people can be completely asymptomatic, not have any disease at all, and be infectious. Our recommendation around this is around 10 days because we don't have that full spectrum of know for sure. I think you know from now that Mike and I, when we answer these questions, if we could answer every question with "it depends," we probably would, because it does. It depends. It depends on your age. It depends on the infectious dose you had. It depends on if you've had vaccination or not. It depends on if you have underlying condition. It really depends. But for the most part, it's really around -2 to +9 days, but it can be a little bit longer if you have severe disease, but you can be infectious if you're asymptomatic. So if you have an antigen-based positive test, we believe you should isolate so that you do not pass the virus to others, because at that point you are infectious and you can pass the virus to somebody else.
And everything is an average.
Yeah.
And that's the thing. The problem, we get lost in averages because we say, well, the average period of infections is 5 days. Oh, that means everybody is not infectious after 5 days? No. That's like saying the average height of people in Geneva is 1.6 meters, then everyone is 1.6 meters high. No one accepts that logic. So the logic of accepting that the average period of infectiousness is X days means everyone is infectious for that and no one is infectious after that makes no sense to the ordinary person in the street. It's a range. If you want to be sure, the reason why governments put cutoffs is they say, well, that's the reasonable cutoff. When we talk about the incubation period, or we talk about you were a contact, why are you followed for 14 days? Well, 14 days is very reasonable estimate of the vast majority of people will develop disease within 14 days of exposure. But there are small numbers of individuals, exceptions at 3 weeks. But if you then say everyone has to self-isolate for 3 weeks instead of 14 days, then everyone goes nuts and says, well, what's the value in that, the price we pay? So we're always trying to find cutoffs that are maximum public health value, but a minimum interference in the life of the individual or the life of society. So what's that line? We do the same with speed limits. We say the speed limit is 70 kilometres an hour, or the speed limit is 100 kilometres an hour. Does that mean that driving at 99 kilometres an hour is perfectly safe and driving at 101 kilometres an hour guarantees you're going to crash? No. There are so many factors that affect what speed is dangerous. If you're doing 100 kilometres an hour on the motorway, it's very different than doing it in the middle of town. If you're an experienced driver, if you're driving a really good sports car that has fantastic brakes and steering and traction, as opposed to driving a motorcycle or something that might be very hard to handle. So everything is relative to the context that you're in. And I think people get that. People understand that there's no absolutes here. These are ranges, they're advisable ranges. And I suppose one of the best ways to find out if you're infectious or not is to take an antigen test, and that side of that. And again, most people, the vast majority of people, will probably be uninfectious within 6 to 7 days of having a symptom. Generally speaking, a healthy person will clear that infection and not be infectious to others. And will certainly, even if they were infectious, will be a hell of a lot less infectious they were on the day they got the symptoms. As Maria said, you're probably the most infectious right around the time you develop the symptoms, right around that. That's when you have the most virus in your system. And what we want to try and do still is if you're unwell and you do an antigen test and you're positive, you should still isolate right now. I know people who, again, who said to me, well, everyone's vaccinated now, so you don't need to isolate. No, not true. If you do an antigen test and you're positive, you should isolate yourself until you're negative, or until the 5, 7 or 10 days, whatever the government advice is in your individual country, because you are going to infect others. If you don't isolate, you are going to infect other people. And at some point, one of those other people is going to be an immunocompromised person or a vulnerable person. And none of us want to be that. You try and minimize the risk you pose to others. And if we all could do that a little more, then we'd be in a hell of a lot better position right now, I think.
And can I just comment on that? Please. Because I think there's a difference between guidance and policy. So what we do is we set the guidance and say, okay, here's what the data is telling us. And we look at these curves and we look at when you're most infectious on average, and then we look at that over time and how that risk of infecting others or your infectiousness changes over time, and we set those boundaries, and it's a range, right? So you hear us nuance our answers because we cannot give an exact answer for anything, quite frankly, but the policies that are set using that guidance depend on what the goals are. And so what we've seen with Omicron, these massive waves of infection, everybody remembers around the course of the year, and governments were setting policies that said, okay, look, we have to get people back to work quicker than we did in the past because society was just collapsing again. And so there's a risk benefit. What are the pros and cons of setting policies that say, okay, look, you can stop isolating after a certain number of days, but there is a risk. But here's the benefit if we get people back to work. But I think what we're trying to say, and Mike articulated this perfectly, if you have a positive antigen-based test, you are infectious. And so it's possible that you will pass it to others. So you need to know what that means in terms of your course of your actions. And we need governments to support people in taking the necessary steps. It's easy for us to say, stay home if you're unwell. It's easy for us to say, stay home if you have a positive test. But that could be life or death for some people, not from COVID, but for other reasons, and putting food on the table. We recognize that, which is why when we do our guidance, we set these considerations. Take into consideration what it means if somebody is infectious and they go back to work, or if somebody is infectious and they interact with an older individual. There are risks, there are consequences to these actions. Those consequences remain. Again, good news is that we have these vaccines that are incredibly effective. We just need to get those to those who are at risk in every single country. Who are we missing in the most at-risk groups? That's the priority that we see going forward. And that doesn't start in the autumn in the Northern Hemisphere. That is happening and needs to happen now. We don't get a reprieve from this. For other infectious diseases, we see some kind of seasonal pattern where we get a break. Nobody needs to think about it for a while. Unfortunately, we're not quite there with SARS-CoV-2 yet. It hasn't stabilized. It's not stable yet. And so we need to remain that level of vigilance. And we need to think about it every day and fight for this every day. The average person that's out there, we don't want you to have to be so concerned about this. We want you to live your lives. But think about, what do I need to do that could keep me, keep my grandparents, keep my family member who has an underlying condition, a child who has an underlying condition that I may know about, or someone I may interact with on a bus. How do we keep that safe? And putting on a mask right now is a simple measure. These masks are widely available and they work. Something like that we want all people to do and live your life. Just live it carefully.
Thank you both. Here's a very interesting question, important question. Mike, maybe you can take it. Is COVID-19 still a public health emergency of international concern? If so, what are the primary differences between our stage in this third pandemic year and where we were in early 2020 when COVID was first declared a fake?
Another good question. Yes, by the emergency committee that looks at this mess last week, and actually point anyone to their report if anyone wants to go look at it on the web. I think it's a really good assessment of where we are right now in the pandemic, and they were very clear in saying in no way is this pandemic over, and in fact quite the opposite. They were concerned about many of the same issues that Maria has spoken to, around complacency, around the fact that we're not reaching everyone we need to reach with vaccine, the fact that we're not doing enough testing. They saw risks right now in terms of both government responses, in terms of the epidemiology of the virus itself, and the continued risk of the emergence of new variants. But when you look at their primary concerns were really around that issue of the gaps we have in vaccination. And that's the difference between 2020 and now. Maria spoke about it earlier. The difference is not that the virus is different. The virus is different and will be different in 2023 and 2024. The difference between 2020 and 2022 is we have the remarkable gift of vaccines that are highly effective. We have diagnostics that have maintained massive quality and predictability over time. We've got new antivirals. We understand the transmission of the virus much better. We understand how to manage ICU patients much better. We're working on the ensuring that we've learned that the careful and timely administration of things like steroids can really help the patient. We've learned about proning. We've learned about oxygen supply. We've learned about early intervention. We've learned so many things about how to do better in every phase of this. We've learned how to avoid infection. We've learned the combination of personal behaviors that reduce your risk. We've learned all of these things about reducing risk of exposure, reducing risk of infection, using vaccines, reducing the risk of death by good clinical management, all of those. So if we apply all of those, then the situation is totally different. So that's, I think, the difference, not the virus. Is what we have at our disposal. We've done well, but we've not done well enough in vaccination, particularly in the equity of that distribution between countries. But even within countries, we have this focus on who we vaccinated. We need to have the focus on who we haven't vaccinated, on who we missed. And governments need to do that much more. So if I was to say, one thing we really need to do in the coming weeks, all countries looking at their plans, is to look at who have you missed. Because the single most effective way of preventing hospitalization and death from COVID-19 is to have a full course, primary course of vaccination and a booster dose if you're in one of the groups that requires it. That is your best bet. That is the best way to avoid the negative consequences of this disease. Clearly, yes, avoid infection. Clearly, yes, see a doctor if you're sick. But if you want to make one investment today, one single thing that you can do that will protect you and your family from the consequences of this disease is to get out there and get vaccinated, especially if you're in a vulnerable group or an older age group or someone who has underlying conditions.
Thank you so much, Mike. Thank you, Maria. And I thank to all our viewers for their great questions today, especially to those watching us from Yemen, India, the US, Canada, Togo, Suriname, Tanzania, South Sudan, Ireland, Egypt, Cameroon, Afghanistan, Argentina, Chad, and many others. Thank you for your questions. Thank you for your time today. And please, as Maria and Mike explained, pandemic and public health emergency of international concern is not over. We have the tools in hand that we can all use. So use them smartly and enjoy summer or winter carefully with your loved ones. Goodbye.